Hello and welcome to SimCast, the higher education simulation podcast. My name's Tony Jeremy. I'm the academic lead for simulation-based education at UEA Norwich.
Hi everybody, my name's Lawrence Hill and I am the chair of the simulation group in the School of Health Sciences at UEA Norwich.
And today we are joined by Christine Vogel, who comes to us all the way from Florida in the United States. Is that correct, Christine?
Yes, that's correct.
And Christine, you work for a company called UbiSim, which specialises in virtual reality technology in clinical simulation. And you're going to talk to us a little bit about VR today.
Yeah, absolutely. I'm happy to be here. Thanks for having me.
No, you're so welcome. Thank you so much for your time and coming on to join us for this international edition of SimCast.
And it's the first time we've done something remote like this, so we're a little bit interested to see how the technology works, which is ironic really, because we're talking about technology in simulation.
Yeah, so we're just going to assert the basic assumption for ourselves here, which is that whatever happens, we are desperately trying to improve. But no, Christine, thank you so much. So could you tell us a bit more about what you do, about what's your clinical background, and how did you get into simulation-based education?
Oh, sure. So like you said, thanks for introducing me. My name is Christine Vogel. I'm a registered nurse, and I've been a nurse for 25 years, which is mind-blowing to me. It's been a blink and it's been a joy. My background is in intensive care and chronic disease management. And when I did that, I just found my love for education. So at that time, I started clinical instruction at the university and was approached by administration to develop a simulation lab and simulation curriculum for nursing programs. And so, I developed a simulation program from basically one mannequin and no simulations to a full simulation program with dozens of scenarios utilizing various modalities. And like many, I had the great opportunity to think outside the box during COVID and do remote learning. In 2021, I started authoring and developing immersive VR simulations for UbiSim. And I absolutely fell in love with so many aspects of virtual reality. So just the ability to do clinical judgment and practice and have those opportunities. I loved the high fidelity nature and to design scenarios that align with the NCLEX. So currently I've been with UbiSim for 3 years. I'm the lead nurse educator. And I have a very varied role. So I design and peer review evidence-based scenarios. I lead the pilots for them. Our scenarios are for novice learners to experienced. So I work with a team of nurses and mentor them and work with their storyboards. I work closely with the product team of developers, which is really awesome. We have a team of artists, developers, user experience designers, quality assurance experts, and we work on developing new features in VR. So I make recommendations on upcoming features and just listen to what our users want. So currently we're developing an NG tube. So we're thinking about what does that look like and how do we use that and how is it intuitive in VR and how will we capture what the learner does with that piece of equipment. So that's a little bit about myself.
Wow, that's. It sounds like you've got quite, like you say, quite an expansive role, really. That you cover quite a lot of different stuff.
And you said you're the lead nurse. How big's your team?
So our team is actually quite small, and so we are a team of about 12, but we're partnered with a larger company, and so we get a lot of marketing and sales support from them. But our team works really closely. It's a very cross-functional role, and I feel like I'm always learning about technology and other pieces, and then our developers and user experience designers and QA, they're learning to be nurses. It's so funny how much they learn about nursing and the nuances of nursing. So, yeah.
Amazing. Well, so, I mean, what better place to say, well, welcome to this episode of VR and simulation-based education. If you are interested in all things virtual reality, please do like this episode and do remember to subscribe and check the notification bell so we can keep you in touch with all things sim. Christine, thank you again. So
I guess we'll have a couple of
so many questions we want to ask.
Yeah, let's start off with thinking about our potential audience. So we've probably got some educators here who are watching or listening to the podcast, and they may well have used VR before, or they might be thinking about using VR for the first time in simulation. It's certainly very much a hot topic in terms of its integration into clinical simulation. So how would one integrate VR technology in good simulation-based education technique? How would you get started, do you think?
That's a really good question, because that's what we want, is great simulation, effective simulation for our learners. And with any technique, just all modalities of simulation, we want to make sure that we're using the standards of best practice. So whatever you're doing in other modalities is really important. From the design of the scenario to integrating it into your program, to the pre-brief, facilitation, and debrief process. So I would say it's really important to make sure that the simulation design follows those standards. And I mentioned INACSL healthcare simulation standards of best practice, and that has been amazing to be able to follow, all of those 10 standards and really develop simulations that are, following those and have best practice just kind of threaded all the way through.
You mentioned INACSL there. For people that might not have heard of that before, what does that stand for, and who are INACSL?
Sure. It's the International Nursing Association for Clinical Simulation and Learning. So it's a mouthful.
I like INACSL. Yes. It's nice and short.
INACSL, it kind of rolls off the tongue a little bit easier, but they have 10 standards of best practice, and, really making sure that your simulations follow those standards is really important. So looking for a product that follows those standards is critical. So simulation design, when you're looking at a VR product, they're likely going to have, a catalog of scenarios. So just make sure that the content experts and simulationists have that knowledge in sim education and pedagogy. There needs to be a needs assessment, just like every other modality, and measurable outcomes and objectives. Just making sure that they're leveled to the right level of learner. And in VR, just like any other type, just having various types of fidelity as well. I think that's one of the things that really interested me in VR, is just really capturing physical and conceptual and emotional fidelity. The first time I put on the headset, I was absolutely amazed by how immersed I felt. And so you really feel like you're in the room. You can see your patient, and it's just very realistic, and you can hear them with great, audio and just authentic dialogues. And then tactile as well. When you pick up the handset, there's haptic feedback as well. So you can feel pulses, you can feel that rate and rhythm, and if it's strong or not. So making sure that simulation is good simulation in this modality, the same way you would in any other modality. And then making sure that there's a pre-brief and debrief. And I think it's important to just get people into the headset and really orient them to the learning experience, just like you would a mannequin or any other modality as well.
What is it like, do you think, for someone who puts that VR headset on for the first time? Is it overwhelming, or, like you said, you're so immersed in the environment?
Yeah. I feel like the first time I put it on, keeping in mind that when I was a simulation coordinator, I didn't have the opportunity to use VR. So the first time I put it on, I kind of felt like, and this sounds a little cheesy, I felt like, oh, I'm in the hospital, that I feel like this is home. You look around and you see everything, and the technology has come so far. So to see patients changing facial expressions, I really thought about my learners and how much they struggled sometimes with that fiction contract, and looking at the mannequin who's having these really difficult conversations with them, and just it was really just refreshing to see that there's another modality that can really tackle learning objectives in a different way. So looking at all of the simulations that we did across our program, I was able to think of simulations in particular that VR would be the best modality for. Just like I'm able to think about simulations that a mannequin would be best for as well. So that's been really, really fascinating.
Yeah, I bet.
It's a really good point, isn't it? It's another complementary way of delivering simulation rather than it's kind of replacing or...
Yeah, it's like the kind of the selection of available methods just seems to get broader. And actually, like you say, like we're all simulation educators. What we're aiming for is competent, confident healthcare professionals at the end of it. And whatever the right modality is will depend on what those learning outcomes are. But I was really drawn to what you were saying about the immersion and the engagement and the fiction contract and fidelity in simulation-based education in general, but specifically in VR, because
it's something that we've discussed before, isn't it? Is how do we get that buy-in from that fiction contract? Because when you've got a patient simulator, a plastic mannequin in front of you, there's always that little bit of hesitation. The learner looks over at the instructor rather than at the mannequin. But with VR, as soon as they put their headset on, they're kind of
forced. You're forced into you're immersed.
You're signing the fiction contract, aren't you?
You're
putting the headset on, and now you're in.
Yeah.
Yeah. It's kind of like that act of putting it on, like that act of taking on that fiction contract. I like how you put that as well. And you really can't escape your patient. You're in there, you're immersed. The patient's looking at you and asking you questions, and it's not like you can do anything except be your real self and do the very best you can to help that patient.
Like, of course, you could take the headset off at any time you wanted if you felt like you had to, but that commitment, the commitment to the scenario, that fidelity to the fiction contract is there all the time you're wearing the headset. And I just love, because my experience of using VR has predominantly been gaming, right? So I've done more gaming, and my experience of that was that putting it on was like entering a new world, but the experience of taking it off was almost as profound as kind of re-entering like the normal world. It was just, I remember just being like, no, I'm having to go back in, just because it's so immersive that it really transports you to a place and time.
But that's a really good point as well, though, because when we talk about when you finish the simulation event and you move to debriefing, you want to clearly define the two as separate, and remove yourself from the simulation event to sort of decharge from that whatever's happened. And no better way of doing that than taking your headset off.
Yeah.
Right. Absolutely.
So how does that work then?
You're getting...
Oh, sorry. How does that work then? So like when you want to debrief your learners after you've done some VR sim, what's the process? How do you do that?
So I think it's super flexible. So with a program like ours, we have pre-brief, and then of course the immersive VR, and then there's a debrief that's available, and it's multi-tiered. So you get session feedback and reflection questions based on the Pearls debriefing framework, and then a quiz. But I would say the really unique and awesome thing about VR is every action that the learner does in VR is captured, time-stamped, and immediately translated to a feedback report. So I remember all of my years of facilitation and, sparks flying off my pen, just trying to take notes of what everybody is doing. That work is done for you. So I think it really allows for the facilitator to focus in on those soft skills that can't be captured at this time, within VR. So just really focus on this scenario unfolding. And then, learners can look at that feedback report independently in groups, or the facilitator can go through that feedback report, can watch a video playback of that as well, if you'd like to do that. And then, of course, really reflective debriefing. So that feedback is very unidirectional. But we need to make sure that we're debriefing in a bidirectional or multi-directional way. And so just facilitating according to whatever framework, and that's so necessary. So whether it's the Pearls or the RAD as well. So yes. That was a little shout out to you.
Yeah, I noticed that. Yeah, the RAG debriefing model. Thank you so much. Yeah, So this is going to feel like it feels like a really naive question, but so the debrief from VR simulation takes place with the headset off. Is that correct?
Off.
Yeah.
Yes, that's correct. Thanks for that clarification. So the pre-brief is going to take place with the headset off. You're able to, take a look at everything, get your S-bar, and then the simulation itself is about 20 to 30 minutes. And the MetaQuest recommendations is you don't keep the headset on longer than 30 minutes without a break. And then that makes a perfect segue to take the headset off and go ahead and debrief in whatever way you normally debrief. And you can do that remotely as well. I think that's another key piece for VR is that your learners don't have to be just in one place.
Sure.
So our team is international. So I do pilots with our team, and they're in Canada and England and Belgium, and we all connect together. We're able to get a feedback report, and then even on Zoom, we can debrief as well.
That's cool. And so quite often we're running simulation in fairly large groups. So there's only a finite number of headsets, or perhaps there's one person wearing a headset. How do you engage, or can you engage the other learners in the group who are perhaps not actively wearing a headset or aren't the kind of protagonist, if you will, in the simulation? How does that work?
The main character.
Yeah, exactly. How does that work?
Yeah, absolutely. So you can have more than one person as the active participant in the simulation. So you can have 3 people wearing the headset, caring for the patient at the same time, and they're able to talk to each other and hand each other the stethoscope and do all of those things, which is great. But then maybe you have, 3, 5 other learners that you're wanting them to observe. And we want them to have the best experience. So there's 2 ways to do that. The first way is to have them put on a headset and be a ghost observer and get a front row seat to that simulation. So they feel like they're right in there as well. The active participants can't see them, so they're not distracting to the active participants in the scenario. And then the other way is you can cast what's in your headset. The active participant can cast their first-person view to a screen, and so you can have observers maybe sitting at a desk taking notes about the simulation and things that they want to unpack during the debrief. So again, that flexibility is there, just depending on how you want your learners to observe.
And sorry, the ghosts, the ghost mode, if you like, are they looking at the simulation through the eyes of the active protagonist or their own view?
Their own view.
Oh, wow.
So that they're standing at the foot of the bed watching the simulation unfold real time right there. So it's a true observation mode. And again, they're super they're present in there as well.
Yeah.
So they stay focused in that. And just another thought as well, I really found another unintended benefit. And so when I did simulation, mannequin simulation, or utilizing standardized patients, we had our observers in the room sometimes just observing. And it was just very nerve-wracking and distracting for our active participants. So that's been another unintended benefit, is when you're in the headset, you forget about your observers. You're just really, it's a more authentic self. That decreases.
You certainly
anxiety.
forget about the environment when you're like playing gorilla tag or whatever it is that people are playing on headsets. There's a reason you get a safety briefing about the sort of the net that's around you, because it is like you lose all semblance of connection with the reality that's outside of the headset.
So again, if I'm an educator and I want to use a bit of VR, I guess I do need a little bit of physical space.
You do
for safety.
So safety is key. So 7 feet by 7 feet is the typical need of space per active participant. And so some companies need more than that because they walk around the bed in the room. Ours, we teleport, and it's a very smooth and so we need a little bit of less room as well. And then just making sure everything is out of the way. And it's so interesting because I get to attend conferences and I hear a lot of feedback, which is so rewarding. But I hear about people opening the med cart and then trying to use their hip to close it because they feel so immersed, or they feel like leaning on the bed. So just kind of keeping that in mind, it is that immersive, just making sure that everything is out of the way. I always have to put my dog out of the room just in case. And so just safety is key.
Oh, that's really interesting. That the translation over there of things to do in VR that they end up translating over into real practice. But that for me is a kind of an indication that some of the learning that takes place must really stick with learners. Like if you're conditioned to open a medicines cupboard by moving your hips in VR, there's obviously transference of learning that's taking place from the virtual reality environment into the actual clinical one. So that's interesting. And I should probably think a little bit embarrassing for that person that tried to open the medicines cupboard with their hips as well.
Absolutely. Yes. I think that's why it's so important when we design features in VR to do it like that cross-functional team, that user experience designer, and just making sure everything is exactly as intuitive as it can be. We want our learners to be caring for the patient and, calling the provider. We want them to be giving medications, doing assessments, and not thinking about, okay, well, how do I manipulate these hand controls? And do I have to use a menu? We want to just be able to have them pick up the stethoscope and listen to the patient, sit them up, move them, and do all of those things. So we just really try and make that super intuitive.
Yeah.
One of the things that we recommend for our learners is tutorials as well. We want to make sure, just like any other modality, we used to do like an intro to the mannequin. Here's where you find the pulses.
Yeah.
And, the same thing for VR. So just making sure that they go into the tutorials, which guide them and show them how to use all of the equipment.
Yeah.
So that when they're caring for the patient, they're actually caring for the patient and not thinking about all of those other things. And it decreases cognitive load too.
Sure. So you've mentioned a couple of things there. You mentioned about the physical space, the surroundings that are needed in order to do this safely. You've mentioned about some of the kind of information that the learners need around how to engage with this environment. What are some of the other kind of, back of house type considerations that people might not necessarily first think about when they think, I need to incorporate VR?
I'm using VR for the first time. What sort of things do I have to consider? How is it going to, what's my extra workload over, a conventional simulation session?
Yeah, absolutely. So space is a big piece as well, but this is kind of one of those pain points that VR can solve. You don't have to do that in a simulation lab. So it's really nice that you don't need all of the setups, all of the supplies, consumables, and anything like that. But you're going to need to figure out what headsets to use. So that's an important consideration. And it's not a one-to-one. So if you have 60 students, you don't need 60 headsets. It depends on how you want to facilitate your simulations. And so you can have, groups or however you like to schedule, but you can also facilitate as a faculty, or you can have a peer-to-peer facilitation, which gets more people in the headset as well. So thinking about what you want that learning experience to be, getting your headsets, making sure that, you've got the Wi-Fi, and it doesn't require, an absurd amount of Wi-Fi. You need a laptop to be able to do the pre-brief and debrief. And then, it's actually quite intuitive and easy. Orientation is a big piece. You want to make sure that your faculty know how to use VR and feel comfortable in that. And I say that with a smile because sometimes learners feel more comfortable in VR than faculty. And would
you recommend that the faculty use the VR themselves fairly regularly?
100%. I don't know about very regularly, but just getting in there, and there's so many fun games. Lawrence, you mentioned a couple, and I haven't done the gorilla game that you mentioned, but our team does do mini golf every 2 weeks, and so we get together across the world and we do a mini golf session together. But the Oculus First Steps, and it's very gamey, and so just get in there and have fun with it as well. And do those tutorials. But it's amazing. People put on the headset and they pick it up very quickly. I was actually surprised at how quickly I picked it up as well.
Cool.
And do you need, again, this might be a bit of a naive question, but I think if my memory serves me correctly, when VR headsets first came out, you needed a very capable computer to run it from. Is that still the case, or can you do things mostly on the headsets now?
You can do things mostly on the headset. So I don't want to speak for all companies, but yeah, it's not cabled, it's wireless, and I just use a standard computer, a standard laptop.
Okay.
And so it's very accessible for learners as well.
And the scenarios, can you run them without a headset, just out of interest?
On the computer?
Yeah.
Oh, no, we are 100%. We're all about that immersion. So you would want to use the headset. If you wanted to do more of a screen based, there's so many different applications as well. I think about when I used to teach in 4-hour blocks, and my poor students, would have to listen to lecture for 4 hours. How cool would it be to, discuss a concept and then maybe myself put on the headset, cast it up there and say, okay, group, what do I do first? And have them walk me through caring for this patient and really solidify, okay, this is the concept of heart failure. This is what we should be hearing. This is what we should be assessing. So yeah, there's a lot of different applications that you can use, again, with that flexibility.
Great, thank you.
That's smart. So where do you think then the kind of optimal place for VR to sit within the current range of simulation-based education modalities are? Like how, like I think, conflict of interest, time, like we've got UbiSim staff. You're obviously, work for a company that provides these kind of solutions, but, we're all, simulation-based educators first. But, how do you imagine the kind of optimal integration of VR with conventional modalities looking like?
Yeah, and does it replace anything? Because I've heard about people touting VR as a potential replacement to clinical placements. I mean, I think we're already hinting at the fact that it's another technique in the simulation-based education spectrum. But yeah, it'd be interesting to hear your thoughts on it.
Yeah, I agree. A simulation educator first, and nurse, just wanting my learners to do well, wanting to better patient outcomes. I think there's a great place for clinical. I was a clinical instructor for many years, and there are things in clinical that you cannot simulate, and so I don't love the idea of replacing all clinicals with simulation. I think the objectives in each are just a little bit different. We're always trying to get our simulation close to the clinical environment, but I know in nursing, it's very different. There's so many things that nurses cannot do in clinical. For instance, hanging blood, giving IV pushes, talking to providers, getting orders, etc. We can't do those things in clinical. And so simulation serves a whole other purpose as well to boost those things as well. My view is that VR simulation complements and scales simulation in programs. So whether those are established simulation programs or new simulation programs, I think it's another tool in the toolbox that educators have to provide a very standardized and effective simulation experience for learners. Again, looking at those learning objectives. So for instance, anaphylaxis was always a tricky simulation, with a mannequin. Because I'd have to pause in between and then moulage and, get all of that going. And then we break that fidelity. That's something we can do in VR. On the flip side, if I wanted to do CPR, I would want to feel that rate, depth, and compression on a physical mannequin as well. So I think just really optimizing each modality for the learning objectives just really maximizes and scales the simulation program and really elevates the experience for learners.
Yeah, I mean, that's
Agreed.
I couldn't agree more with that.
As usual, go back to the learning outcomes. Keep it simple.
Yeah, and choose your tools according to what you're trying to achieve. Yeah, no, that's great. Thank you. So
absolutely.
So then what does the perfect day of simulation look like? Let's say you've got a group of learners in, they've done some theory away from the kind of practical component. They've got some underpinning knowledge to work with. How does a day of simulation that incorporates VR look like to you?
Oh, that's a great question. And I'm going to say that one's going to depend on my learners a little bit and how knowledgeable they are, with VR, with simulation as well. And that's going to kind of dictate how long I need to pre-brief, and then the simulation and then the debrief as well. So if I had a group of 6 learners, gosh, I could even say 8. It's very rare that I would have a group of 6 learners. It seems like those groups get bigger and bigger. I would run probably a peer-to-peer facilitation with them to make sure that they're broken off into groups of 2. One puts on the headset, one facilitates. And when I say facilitate, the simulations unfold according to the learner's actions or inactions. So there's nothing on the fly. The facilitator isn't moving through the simulation in that way. They're just triggering dialogue that makes sense during each state of the simulation. And I love that observer role as well, because it asks the facilitator to have some empathy, to put themselves in the shoes of the patient or the family member. So that is a key learning objective as well. And then, I would have them do their simulations and switch and repeat simulations, which is another benefit of VR. You don't have to do a whole setup again of your sim lab. You can have them switch and put the headset on the other person. I would hop in with my headset as a ghost observer into those sessions as well, and take a look at how they're doing within that. And then I would go ahead and debrief. So I would look through the session feedback. I typically don't do a video playback, but that is available as well.
We found that as well. With conventional sim, we found video playback can be almost a little bit sort of jarring almost and difficult to coordinate. Yeah. Anyway, sorry, I interrupt.
Yeah, absolutely. I feel like you lose that flow of that organic debrief where learners are just sharing and reflecting. And if we're doing it right, we're facilitating and we're hearing their thoughts and they're coming to their conclusions and reflecting on their actions and beyond their actions as well. And so that's what that day would look like. So if it was one simulation, I would say that experience that I described could be 3 hours. So I think you can kind of judge and scale and adjust that timing according to your learners as well. But I'd really spend, a lot of time in that debrief and talking about their experience and using a structured debriefing framework, which is absolutely key as well.
I'm just going to take a moment here just to have a quick shout out, because that what you mentioned there about 6 to 8 learners, I'm just really interested to hear what the experience is like of the people listening or watching this podcast. Like, how many simulation learners would you normally have in a given session? Is it 6, is it 8, or is it potentially more than that?
20, 24.
Yeah, and because I think that's the thing for me, is that what VR appears to offer to me is a highly replicable, immersive, but also really quite efficient way of ensuring that continuity of experience for learners. It's really hard, isn't it, when you're doing simulation in person to kind of rinse and repeat?
Yeah,
because actually that takes quite a lot of cognitive energy from faculty to continue to repeat simulations. I talk about getting a kind of a repetition dementia, where I'm with the 4th group and I can't remember if I said, did we talk about, which group was it that we had a conversation about this aspect of practice, and simulation using VR negates some of that. So I'd be interested to hear how many learners you have. But the other thing I thought was simulation technicians, they must love VR. Or some must, because like how
the resource saving,
the resource intensivity of using VR compared to the number of mannequins and the number of, like you say, preparation and things. There must be some benefits to that too.
Yes, because after some simulations, you go into the sim bay and it looks like a full-blown code has happened, and you're starting from scratch, cleaning up, finding all kinds of bits and pieces, and then moulage, just sanitization. There was just so much to do after each simulation. And I will say, as the sim coordinator, I had countless numbers of learners who would come to my office. Can I come for just to practice in sim? And I hated turning them away just because we were booked. We had no space. We've already, had the consumables ordered. We had exactly what we needed. So I feel like this is an amazing way to practice and do that deliberate practice and just build confidence for learners as well. So yeah, if you had observers that their role was to observe either watching the screen or being in as a ghost observer, they could also do the simulation again, and it would be a standardized experience. They would have that experience as well. I think it's good for facilitators and faculty as well, because that dimension that you spoke of, I know voicing a patient all day long can be very taxing.
Yeah.
And so at the end of the day, faculty maybe, and I'm included, it may be a different experience than that fresh first case in the morning. And so having that standardized dialogue just really makes sure that the learners have that standardized experience as well.
Yeah, it is a really important point, because there are some significant kind of ethical considerations with asking people to play a bereaved person or a victim of sexual violence, or something which is powerfully emotive and potentially quite traumatizing for a person to do that several times over. So yeah, I can see how in those kinds of situations there is a kind of an emotional burden which is no longer falls to facilitators, which is I hadn't thought of that until we were talking just now.
So with one of the first episodes we did of SimCast was a Technophobe's guide to using technology in simulation, and I'm sure we've got some educators out there who are quite excited to use VR but might be a little bit apprehensive just because of the technology side of things. So what sort of advice would you give to those individuals?
Gosh, I would say just get in the headset. Seeing is believing. It's one of those things that sounds, but just getting people into the headset and having them experience caring for a patient, doing a tutorial, and just getting that feel. And then really helping them to understand that this modality is there to help as well. So we mentioned so many benefits during the podcast today, but this is to decrease the burden on them as well and provide an amazing experience for learners. I think supporting faculty is really important as well. So we don't want to just be like, okay, here's the headset, here's the program, off you go. Just, making sure that we support our faculty. So if there's an IT program that, make sure that there's great connectivity, or a sim ops specialist is amazing to help faculty with technology as well. But getting into that headset, number one. Number two, getting learners into the headset and just piloting with a small group of learners and hearing their feedback really is a game changer. So we hear feedback all the time about how realistic it is. VR is, in learners, it's exploding on TikTok even. People are talking about VR and how immersive it is and how they're loving learning in VR. And so I would say just give it a try, just like any other modality as well. 10, 15 years ago, mannequins, sat in boxes because people were afraid to use them. They would be in the closet.
Absolutely.
But then just building that confidence with them, just using them in a small scale, and then, growing and growing really makes all of the difference. So yeah. Getting the headset on is the first step.
Yeah,
great.
Don't knock it till you've tried it.
Absolutely. Now, interestingly, you talk then about patient simulators 10 or 15 years ago, and when they were new technology being left alone, and obviously VR is still, I guess, relatively in its infancy when it comes to healthcare simulation. So, if you had a crystal ball, and without giving away any trade secrets, what would you say the future of VR in healthcare simulation holds?
Oh, that's a good question. I think as the technology advances, integration with AI and machine learning and hand tracking and sensors is going to maximize the impact of immersive VR. So currently, it really tackles the cognitive and affective domains of learning, and a little bit of psychomotor as well, but it's really hard to do those fine psychomotor pieces with the handset. So I think as the technology increases and advances, we're going to see an absolute explosion in impact as well. So the literature really continues to show that VR is an effective evidence-based modality offering realistic, safe practice, hands-on practice and opportunities for learners to prepare for clinical practice. So I think VR is here to stay, and we're seeing it grow so much. And I think what you highlighted as well, it's not going to replace other simulation, because remember, simulation is a technique, not a technology. And we need to make sure that we're using the best technology and the best modality for the learning experience we want to cover.
Perfect.
Yeah, absolutely perfect.
I think that's a lovely way to start to draw this episode to a finish. So, Christine, thank you so much for taking the time. It's quite early where you are, isn't it, to come and speak to us today?
It's early, but nurses work around the clock. So we're good.
Well, thank you again, Christine. It's been really interesting to get your insights, and it's lovely. And hopefully we can catch up in person one of these days, and we can continue the conversation.
We'll come to Florida.
Yeah. Thank you for the invitation to Florida. Actually, Christine, we're really looking forward to coming to see you out there.
You're officially invited.
Yes. All right. Okay. Well, thank you very much. And thank you for listening to this episode of SimCast. We hope you've enjoyed it. If you have, please do like and drop us a comment. We'd love to hear what you've made of today's discussions.
Thanks, everyone. Bye-bye.